This program is brought to you by Emory University.
Good morning, everyone. Welcome to Cardiovascular Grand Rounds. It is my pleasure to introduce one of our own, Dr. Anand Shah, who is an assistant professor here in electrophysiology. Anand has had a unique background starting his career as an active duty physician in the US Air Force, where he was there for 11 years and rose to the rank of a major, and then moved to Emory to join our clinical sort of practice in 2016. Anand went to Albany Medical College and did his internal medicine and cardiology residency and fellowship at San Antonio Uniformed Services Education in Texas, followed by his work with the US Air Force, where he was basically directing a very busy outpatient cardiology practice. And also, interestingly, he's not only board certified in cardiac EP, but also heart failure. So that's one of his other passions and interests. He's a member of the Heart Rhythm Society and fellow of the American College of Cardiology, has received a number of honors and awards, a lot of teaching awards, including meritorious service awards at the US Air Force. So I'll turn it over to Anand, and he's going to talk to us today about persistent atrial fibrillation, a new landscape.
Thank you, Pooja. Good morning, everyone. I probably should have picked a different title. I think when you see persistent AFib as a topic of a lecture, I think we're all sort of trained to think, well, the story is written on that. It's a bunch of rate control, maybe a pacemaker, don't use digoxin, and that's kind of the end of the story. And partly that's why I wanted to give this talk, is that I think that the literature and the story on atrial fibrillation is evolving, like everything else in cardiology. And what used to be sort of the end of the road in terms of a rhythm diagnosis, to me at this point now is really just the start of a new road. There are a lot of paths that can be taken to help people do better with this rhythm diagnosis. Truthfully, I think AFib, and particularly persistent AFib, is an area of great discussion and controversy within the EP field. Within our own department, when we have journal clubs where we talk about AFib ablation, persistent AFib ablation, we all have similar viewpoints on some things, but this is one topic where we pretty reliably have fairly varied viewpoints, and so I think it just reflects how things are changing and how things have gone with AFib. All right, so our definition of AFib, just to take care of the housekeeping, it's AFib that lasts more than 7 days or requires cardioversion to correct. And typically, if you're using the latter definition, we'll say that it should be there for 48 hours. The big deal here is that it implies a much more abnormal substrate compared to paroxysmal AFib. The left atrial size is often bigger. There's more left atrial myopathy, either as measured by electroanatomic data or as measured by atrial performance. The treatments, particularly rhythm control treatments, have historically been much less successful at curing the arrhythmia as compared to ablation. We're going to touch on a lot on the treatments here. The talk is meant to mainly be a discussion of persistent AFib. So the EKG you see here is, of course, a very irregular and tachycardic rate without organized atrial activity. This is a typical EKG of AFib. So starting the discussion with the symptoms is very important, because ultimately the treatment of AFib is targeting the symptoms. So patients may present with quite a variety of different complaints related to AFib. This can be things like palpitation, shortness of breath. In some cases, angina can be a symptom. These typically are driven by the tachycardic heart rate or the irregular pulse rate. Now, other folks will present more with symptoms of function, atrial systolic function. So those might be related to dyspnea or pulmonary hypertension or mitral regurgitation, specifically type B or annular dilation mitral regurgitation. There is a small diminishment in cardiac output directly from loss of atrial contribution to systole, but there's also a loss of cardiac output related to irregular filling, suboptimal filling parameters. So if you take a ventricle that's stiffer or it has aged and add AFib into that, the filling of that atrial, the filling of the ventricle may not be optimized. Interestingly, there's a lot more data coming around with cognition. This is probably another symptom of atrial systole. So this is a long-term sequelae of AFib, and it manifests as dementia. That data is pretty clear at this point, though this is not a short-term symptom, rather a long-term symptom. Knowing where we're starting in terms of patient symptoms is important, because when we ultimately swing around to how to treat AFib, the treatment should be tailored at what symptom we're trying to get rid of. All right, so again, a little bit of a historical perspective. Where were we before? Well, in the late 90s, early 2000s, there were several big studies that were published in big journals. You see here a couple New England Journal studies that looked at essentially rate control versus rhythm control. Affirm is probably the best known of all these. This is an antiarrhythmic trial. And it was a trial where the outcome was mortality. It was major cardiac events and mortality. You see the graph on the left under the title Affirm here shows that the rhythm control arm actually had a slightly higher mortality as compared to the rate control arm, as measured out to about 5 years. The graphs diverge at about 2. This difference was not statistically significant, but the trend was there. And for sure, we could say from this data alone that there was not a mortality benefit conferred to the rhythm control strategy arm. Now, Affirm is not an ablation study. This is an antiarrhythmic trial, predominantly class 3 antiarrhythmics. Sotalol and amio were the more commonly used antiarrhythmics in this. And therefore, the outcomes are essentially, you're going to weigh antiarrhythmic drug toxicities as compared to toxicities and efficacy of medicines like beta blockers and calcium channel blockers, and to some degree digoxin. Secondary analysis later, as we try to to sort of tell the second story from Affirm, turns out that in the rhythm control arm, as was common back in this era, patients who were in sinus rhythm at time of a 12-lead EKG, their Coumadin was stopped. This was a Coumadin study as well. Whereas in the rate control arm, the Coumadin was not stopped. They were left on Coumadin. So much of the mortality difference was explained by patients who were basically not on anticoagulation despite having AFib. When we think about whether or not Affirm really tells us that, hey, this is it, rhythm control is no good. Well, I think what it probably tells us is actually that anticoagulation is extremely important. Now, the chart on the right here, the Van Gelder study, this is race 1. And this was a persistent AFib study where they took people who had failed cardioversion and they looked at rate control versus rhythm control. The goal heart rate was less than 110 beats per minute for the rate control arm. And there you saw that, again, that your event-free survival was higher in the rate control arm. And so, basically both studies were complementary and showed that whether you have paroxysmal AFib, as in Affirm, or a more persistent substrate, that rate control seemed to be, equivalent to rhythm control. And that was all we wrote. That was it. Race 2 came out later and said that more lenient rate control was okay, that you didn't have to go very strict. Affirm had a resting heart rate goal of 80 and a moderate exertional goal of 110. So we don't use that goal anymore. Newer data has started to get published. There's been a whole flurry of AFib activity, starting with EAST-AF. This is a New England Journal study that was published just at the end of the year in 2020. This is a large study, 2,800 patients with relatively recent onset AFib less than 1 year. This is another rhythm versus rate control. This is not really an ablation study. As you can see in this chart here, this panel is the rate control arm. This is the rhythm control arm. And the blue is the AF ablation strategy. And you can see at maximal, the percentages is 19%. Mainly this is medicine, this is for rhythm control versus rate control. And What we found here, if we use a composite outcome of all the sort of bad things that happen with a cardiac condition, that's hospitalization, stroke, death, heart failure, actually your rhythm control arm came out ahead. So this was exactly the opposite. Granted, we're throwing a broader net on outcomes, not just mortality, but exactly the opposite of what we saw with Affirm, with Race 1, and with other studies that in the 90s era. This is a pretty big deal, in my opinion. The real conclusion here is that while both approaches, rate and rhythm control, are very reasonable, the rhythm control strategy may actually confer additional benefit compared to simple rate control. Now, again, this is not an ablation study. This is a medical therapy largely study. So in other words, it says, hey, maybe start antiarrhythmics early. The other interesting part here that I always like to look at here is the crossover rate. There's a 15% crossover here. And what that tells me is, and the reason to pay attention to that is, it tells you that there is a significant chunk of patients who, if you randomize those folks to a rate control strategy, their symptoms will mandate that you actually take their AFib more seriously and that you ablate or treat their AFib as a rhythm condition. It tells me it's an answer to a critique that's very common that, that it's a sham benefit or what have you, but rather that AFib, even if you make people prove it twice to you, they will prove it twice that the AFib is for many people symptomatic. Not for everyone, but for many. So here are the efficacy outcomes. Why do those curves look like they do? Well, interestingly, no single component of the primary outcome actually drove statistical significance. And instead, every bit of the outcome was a little bit better in the early rhythm control. So, if you look at sort of death here, a little higher death rate and rate control, a little higher stroke rate, a little higher heart failure, et cetera, et cetera. And taken together, that's why you get the benefit of, that's why the curves look like they do, favoring rhythm control as an early strategy. East AF was not purely persistent AFib. In fact, it's really more of a paroxysmal AFib trial. So here's early AF. This is another New England Journal study. This is from Canada. And what this trial showed us is, instead of using an antiarrhythmic medicine, if you were to randomize folks who come in with their first episode of AFib to an ablation procedure, specifically using a cryoballoon energy source as their first line therapy, how do those folks compare against those who are randomized to antiarrhythmic drug therapy? And what we see is that at 1 year, ablation is far more effective. Now, this chart here is a percentage of time in AFib. They monitored each of these patients with an implantable loop recorder. So they got the best possible data out of this trial, and they were able to very precisely quantify how much AFib their participants had. The median AFib burden in the ablation arm is 0%. The range is, the interquartile range is 0 up to 0.8%. So it's a very tight coupled or tight interquartile range where ablation really works very well if you look at percentage of time in AFib by a loop recorder. Now, truthfully, the antiarrhythmic drug therapy arm, on this exploded graph looks like it does a lot worse. Well, it did do worse, but the overall burden or the percentage of time for the antiarrhythmic drug arm was still, under 2%. So both strategies seem to work pretty darn well, though if the goal is to get rid of the AFib or to reduce the burden specifically, ablation does seem to be better here. So this was a very interesting study, and what it tells us as we march through our data is that early intervention of AFib seems to make a difference in terms of outcomes that matter to us. Not just patient symptoms, which should matter the most, but other, other tangible outcomes such as cardiovascular death, heart failure, hospitalization, stroke, et cetera. And if we then divide that strategy of how are we going to take an or a rhythm control approach, ablation is better than the drugs. All right, so is persistent AFib different? Well, Cabana is a very large study that got a lot of press. This was a very difficult study to enroll, and about half of the patients in Cabana were persistent AFib patients. Cabana ultimately was meant to answer the question once and for all, is there a mortality benefit to ablating AFib? That was the goal of the study. And they had a bunch of secondary outcomes, 13 specifically, quality of life, stroke, hospital days, et cetera. But basically, this was a mortality study. And what it showed us, if we just look at the outcomes, that drug therapy and catheter ablation have essentially the same mortality rate if you look out to about 5 years. Now, in terms of if you lump in heart failure, or excuse me, cardiovascular heart hospitalizations, okay, well, then you start to see a little bit of a benefit to ablation. That's this panel over here. But if you just look at all-cause mortality, the ablation in this study did not save lives. All right, well, while cardiology largely always lauds itself and strives to use clinical studies to assess the biggest outcomes, right? This is, I think, the history of cardiology. If you go back to ISIS or the Gusto studies or the TIMI studies of acute MI and all the way, forward into the big heart failure studies, et cetera, we always want to show a number needed to treat to save a life. Well, that standard for AFib misses the point. I think AFib is not a disease unto itself. We're going to look at that over and over again through the course of the talk, but rather AFib is part and parcel of a larger cardiovascular milieu. And so targeting one little bit of that milieu and ignoring the rest and expecting mortality benefit was probably a foolish thing to look for. It wasn't going to work. But I think another critique of this study, a big critique in my mind, is in Cabana, 30% of the patients who were assigned to drug therapy crossed over to ablation because of symptoms. So that their doctors had no choice but to do something different with them because of their symptoms. Now, the analysis is on intention to treat. And so ultimately, what this study comes down to is, in some ways, this is an ablation versus ablation study, not an ablation versus drug therapy study. With 30% crossover is pretty darn big. The other thing that the Cabana study does show us is that if you get an AFib ablation, it works. You're 50% less likely to have AFib if you do the ablation compared to if you use an antiarrhythmic drug arm. And that's why the crossover was there, is that the drugs don't work as well as the ablation. The other nice thing here is that anticoagulation use in this study was much, much higher than in AFFIRM, and that drove very low event rates. So all in all, the mortality rate was pretty low, unexpectedly so based on AFFIRM. And I think the reason is that by the time this study was done, people had figured out not to stop the Eliquis or the Coumadin, and that really made the whole event rate lower. Peter Noseworthy did a very neat study using a huge database, an insurance company-based database from Optum, which is a conglomerate of insurance companies. And what he sought to do was replicate Cabana without the crossover, and to basically do that study in a much shorter time frame. So using essentially a analysis of a database, he's able to replicate Cabana, which took 10 some odd years to enroll. He was able to replicate it and get way more patients. Instead of 3,000-4,000, he got 180,000 patients. And when he did that, when he replicated Cabana without the crossover, what you see is that in every single outcome, primary endpoint outcome, the ablation arm is favored. There is statistically significant benefit to ablating AFib when you wipe out the crossover. And that, I think, is very impressive. Now, granted, we all know in terms of clinical data, we take the randomized control trial, but I think this is something that we just can't ignore. 180,000 patients, no crossover, and you see that the hazard ratio for mortality, for all the things that, the hard outcomes favoring ablation. All right, so why do the antiarrhythmic drugs have issues? I think it's worth just stating that these are not benign medicines. The class 1s all reduce inotropy. Some of them have anticholinergic side effects like diisopyramide. Some of them promote ventricular arrhythmia, like flecainide in patients who've had MI. Class 3 medications like sotalol will have reduced inotropy, can prolong QT, and also are negative chronotropes, which may increase your risk of needing a pacemaker. Amio, we all know, creates a whole host of long-term issues, some of which unfortunately are permanent and quite dangerous. So these are the reasons that ablation, why we keep pushing forward with ablation strategies, with ablation trials, is because we recognize that not only do antiarrhythmics not work so well, according to the evidence, but they also have potential harm, long-term harm. So we trade short-term procedural risk for long-term antiarrhythmic drug toxicity risk if we favor the drug treatment arms. All right, so what are the lessons here from the first studies here, from AFFIRM to EAST? Well, previously, the strongest predictor of mortality is your anticoagulation use. So that's what we learned from AFFIRM, is that if you want to know why there's harm in rhythm control or rhythm management arms, it's because people were stopping Coumadin, and that's not a good idea. The other lessons we learned is that all of the medications, whether they be rate control medicines or rhythm control medicines, have associated risks. The RACE-2 study and the RACE-1 study, where they looked at how aggressive should we be with beta blockers and calcium channel blockers, showed that if you strive for tighter rate control targets, i.e. you use more medications like beta blockers, you increase your risk of needing a pacemaker or of having syncope or having a hospitalization for bradycardia. Similarly, the rhythm control strategy trials have shown that these antiarrhythmic drug therapies carry with them risk of toxicities and adverse events as well. The biggest, I think, broad lesson that we can see is that the benefit of all these AFib therapies is best measured in soft endpoints, right? So really, it's the reason to do an AF ablation or to start antiarrhythmic drug therapies for many, many people is symptom reduction. It's quality of life. And some folks, it's heart failure optimization. These are not insignificant treatment goals. In fact, a lot of the things we do in modern medicine are targeted exactly at that, at symptoms, at quality of life. When someone gets a knee replacement, it's not because it makes them live longer, it's because it makes them feel better. To allow a life without pain is an important goal. AF ablation, in my mind, is the exact same. When we stent or open a chronic total occlusion for intractable angina, that's a meaningful goal of relieving angina. And this symptom reduction goal, in my mind, is just as meaningful from AF. Freedom from AF as an endpoint for clinical trials is not, in my mind, a reasonable treatment goal. It treats AFib as a lone disease. It ignores the fact that in most folks, AFib is a symptom of many other disease states. And therefore, the electrical treatment of AFib should never be expected to cure all those other disease states, your diabetes, your hypertension, your sleep apnea. Many studies are starting to move toward AF burden reduction or symptomatic AFib. And when we use those, we find that all these studies report very, very impressive reductions in AF burden and impressive reductions in symptoms. Treating AFib and ignoring risk factors is a recipe for disaster, a recipe for failure. So in patients who come to the lab for AF ablation, in my cases, we're always talking about sleep apnea. We're always talking about weight loss and exercise. We're addressing blood pressure. We're addressing heart failure medications. We're looking at valvular disease. We're adjusting diuretics. We're looking at left atrial pressure. I think this is a way of optimizing outcomes. All right, and finally, in almost every study, if you compare the folks who are in AFib to those who aren't, the sinus rhythm group will, over the long term, have less morbidity and less symptoms. And that is very, very consistent. And I think that speaks to the fact that getting rid of AFib is trying to reduce that burden is a very reasonable treatment goal. All right, so I think from this slide, I guess I'll skip this and move on. So let's shift gears a little bit and start really hammering down on persistent AFib ablation. The traditional paradigm is a progression of paroxysmal AFib slowly morphing into persistent AFib, and then after a year, morphing into long-standing persistent AFib. Not everyone agrees with this paradigm. There are many folks who will not progress from paroxysmal AFib to persistent, but we do know that once this transition occurs from paroxysmal over to persistent, the treatment efficacy of catheter ablation starts to go down. And so catching folks at this transition, or ideally before, makes a big difference. But what happens to those folks where you can't catch them and now they have persistent AFib? Well, the goal of catheter ablation of persistent AFib remains, the number one goal is to create a rim of electrically inexcitable tissue around each pulmonary vein. This is derived from observational data by the Hasseguer group in France in the 90s that AF triggers, and later other groups have shown that some of the that AF triggers come from the pulmonary veins and some from the antrum of the veins. And so treating these veins and creating this electrically inexcitable rim of tissue is a means to eliminate triggers. In some cases, it also eliminates substrate. So we can think of an initiation event of AFib, whether that be a sequence of PACs, for example, as the trigger, and then something has to be there to make the AFib sustain. That's the substrate, that's the tissue. So when we think about ablation strategies, we largely start to think in persistent AFib of how do we get rid of the triggers? How do we get rid of the substrate? Both are going to be required to get optimal results. The current available technologies include radiofrequency ablation, where you essentially create a lot of heat to cauterize muscle, cryoablation, which is a balloon strategy where you create frostbite. You get to negative 60 degrees Celsius inside the balloon. That's this one over here. Laser is out there. This is a way of essentially destroying tissue with a laser that's given through the balloon. Pulse field ablation is a newer technology that is very specific to heart muscle. By tailoring the burst of energy, you can sort of dial in on the heart muscle and create an electroporation injury. You can see here, as an example, these little signals are are pulmonary vein potentials. They indicate that the pulmonary vein is connected to the rest of the heart. This basket catheter, it looks like a flower, is inserted into the vein, and the apparatus is turned on. A very short burst of energy is deployed, seconds or less, and that electroporation injury eliminates the potentials as sort of a one-shot treatment. This is a newer technology. Each of these has inherent limitations in terms of what you can do with them. Each of them has the possibility of transient ablation, not permanent. And therefore, each ablation strategy has, this is why ablation doesn't work every time, is that sometimes based on the energy that you're using, the limitations they'll limit you. So the lesions that we create matter a lot. If you're using a radiofrequency energy catheter, whether you drag the catheter across the heart or whether you leave it in one spot and turn it on, and when the ablation is done, turn it off and then move it to a new spot, that matters. We have developed quite a few lesion quality markers. This is based on 3D electroanatomic mapping and contact force. How firmly is the catheter touching the heart muscle? How much energy is applied for how long? How much current is delivered if you're using a radiofrequency? All these things are determinants about how big and permanent the lesion will be. You see, Elad Antler has done a lot of work here on this. These are pictures of catheter ablation where if you take a lot of energy, say 50 or 90 watts of energy, and apply a short burst compared to, say, 20 or 30 watts and apply a longer burst, the high power creates a much bigger lesion. Over time, that lesion is more durable. The standard lesion, actually, visibly, you can see doesn't look quite as good over the long haul after healing has occurred. When you look at the gross sample, what we see is a more transmural lesion in the high power arm, where we give a large amount of energy in a short amount of time, versus the standard arm, where we give smaller amounts of energy over longer periods of time. indeed, over a long time or over the healing, that turns into a complete ablation scar. One of the earlier studies looking at contact force in terms of durable or successful AFib ablation looked at average contact force as a retrospective analysis. And what you can see is that unsuccessful ablations, if you looked at recurrence at 12 months, if the energy application was delivered at 0 to 10 grams of force, they all failed. If you had 10 to 20, you're half and half. If you're greater than 20, now you're starting to get 80% success rates. This is in a group of patients who were studied twice. And I think this is very telling data that, without that information, in some ways, we're operating blind. If you don't really even know how much you're touching the heart muscle, you may be subjecting yourself and your patients to these sorts of failure rates, which are quite dramatic. Cryoablation is very commonly used, and in many ways, it's supposed to be a lot simpler. You inflate a very cold balloon, you stuff it into a vein, the vein is occluded. You demonstrate occlusion by injecting contrast on the vein side of the balloon and seeing that the contrast cannot escape past the inflated balloon into the heart. And then you turn it on and leave it there for 2 minutes, and then you turn it off. And that's it. It's supposed to be done. The difficulty with cryoablation is that the balloon, when you mash it into a vein, is malleable. And so it's more easy to get that occlusion. But as it becomes cold, it becomes rigid, and it assumes a perfectly spherical shape. If the vein interface to the heart is not perfectly spherical, then you might open up gaps. And sometimes it's really hard to know that a gap exists because the veins will isolate acutely, but they will reoccur over the long haul. There's been a lot of work done on how to predict durable cryoablation, and we have seen that cryoablation dosing has changed quite a lot in the last few years as well. So we're getting better at those lesions too. Here's an example of a study, a case I did not too long ago. The green signals are a catheter placed in the pulmonary vein. Following ablation, we see nothing in the vein. So we see sinus rhythm and no activity in the vein. A dose of adenosine is given to change dynamically and transiently change the cell membrane potential. And what we see is that there's heart block. Okay, that's the adenosine. But we see now that the signals have recurred. The pulmonary vein that I thought was treated, no signals, was not treated. Additional therapy was required. This is something that if we had not given the adenosine, we would have never known. So it's taking more steps and more challenges to really prove that the work that we're doing is durable and adequate. This is a cryodosing paper by Andrade. He's one of the authors of an earlier paper. But what we saw here is that if you look at pulmonary vein reconnection with cryoballoon energy, there's going to be reconnections within 20 minutes and 5%. And if you, at the end of 20 minutes, give adenosine, another 5% will show what we call dormant conduction. That's this kind of thing, where it looks good, but you give the adenosine and it's not good. And so now all of a sudden, 10% of patients in using a cryoballoon energy source may actually not have durable therapy, but require extra steps and extra time to demonstrate that. Indeed, if there is reconnection, the hazard ratio for subsequent atrial arrhythmia is 2.4. And that's only with the cryo arm. With the radiofrequency energy arm, reconnections that were treated, in this study, they were all treated, the reconnections. The reconnections seem more durable. What that tells me is that if you're using cryo and there's a gap, it may not be that you just missed the spot. It may just be that the balloon isn't going to get that spot, no matter how many times you apply the energy. Here you see some of the treatment arms, the efficacy rate for event-free survival. This is arrhythmia event-free survival. The radiofrequency arm at 12 months is about 80%, 4-minute cryoablation, 78%, 2-minute cryoablation, 73%. These are all pretty good numbers. The radiofrequency comes out just a tiny bit better, not statistically significantly different than a 4-minute cryo or a 2-minute cryo. So not only do each individual lesions matter, but the lesion sets themselves matter. And this is really like everyone's very different on this, but at baseline, we know that we want pulmonary vein isolation. That treats the triggers of AFib and some of the substrate, which is the antrum around the veins. Other targets include things like CAFAs, that's complex fractionated atrial electrograms. This is a means of identifying and ablating abnormal substrate. Additional linear lines, like for example, connecting the two superior pulmonary veins on the left atrial roof, or connecting the inferior vein down to the mitral annulus. What this does is it eliminates possible circuits for future atrial flutter. Posterior wall isolation has garnered a lot of recent attention. This is a means of reducing significantly substrate. It reduces triggers that may exist in the posterior wall, and it also treats two potential mechanisms of common atrial flutter. That's roof flutter, specifically, and any left posterior wall flutter. Left atrial appendage isolation can be done where we electrically actually isolate the left atrial appendage. That's both a substrate for AFib, the left atrial appendage, and a trigger. And then finally, right atrial ablation can be done, is often paired. Some people will do typical flutter lines, whether or not flutter has been demonstrated, knowing that the two are commonly found together. Some people isolate the superior vena cava. In some series, we see that SVC triggers can account for 10% of AFib. And so you can see that this is, quite a smattering of different treatment options. And this is part of the reason why it gets very difficult to explain durability and AFib ablation, is because there's just so many different treatment options. So let's just go through a few of these here. First of all, cryoablation for persistent AFib. This is the STOP AF trial. In this trial, it's sort of a very modest outcome goal. They were basically saying, we want to show that we can get 40% success in terms of treating AFib, a persistent AFib, after a cryo balloon. 40% seems like a very poor goal, but that's where they set their goal, and they met it. Their success rate was 54.8%. And the procedure was short, 2 hours. It's very safe. And this is a treatment where you basically only do the veins and some of the antrum of the veins with a cryo balloon. So if we think about what is the success rate for PVI, pulmonary vein isolation alone for persistent AFib, maybe this trial shows us that it's not very good. It's probably about 55%. Of note, very few patients got that adenosine challenge that we mentioned earlier, that it can predict 5% recurrence rate. So maybe they could have done a little better with this percentage if they had mandated that adenosine challenge. Here's a regression analysis of all those different treatment sets, specifically in persistent AFib. And so, to the right of the red line favors the extra ablation. So you see that linear lesions, CAFA ablations, that's the fractionated stuff, ganglion plexi, which is a way of treating specifically vagatonic AFib. None of these things really came out ahead, but posterior wall isolation comes out ahead for persistent AFib, and left atrial appendage isolation came out ahead in favoring doing this to treat AFib, persistent AFib. Granted, for left atrial, this is for appendage isolation, very small numbers. If you look at procedural predictors on the time, so specifically how long the time is, each of these things takes a lot longer. Lines like a roof line or a mitral line adds 20 minutes. CAFA ablation adds 60 minutes. GP, ganglion ablation, 10 to 20 minutes. Posterior wall isolation does not actually add that much time. Left atrial appendage isolation, about 30 minutes. So now all of a sudden you have to be willing as the operator to spend the extra time if you want to get the benefit, say, of a posterior wall isolation, or if you want to do these linear lesions, you got to take longer. So there's a time cost to doing more. STAR AF was basically a study looking at pulmonary vein isolation plus those complex fractionated atrial electrograms. You can see some of the representation graphics, where this graphic is a treatment set where each dot represents a single RF energy application, and they ablated essentially around each of the 4 pulmonary veins. In this one here, they have ablated some fractionated atrial electrograms here in the posterior wall. And here anteriorly, they've ablated some more. And what we found there is that if you do both, veins and complex in this trial, veins and complex electrograms. In this randomized trial, you see a greater freedom from arrhythmia in both paroxysmal and persistent, statistically significant. I'll summarize these as a theme in just a moment. In STAR AF2, they did lines plus CAF plus the pulmonary vein isolation. So they added another piece. And what we saw there is that your freedom from AFib seemed to be driven mainly by the pulmonary vein isolation. If you add more lines in, you get more atrial tachycardia. So the more you treat, the less likely you are to have AFib, but the more likely you are to have, say, atrial flutter. Interestingly, the majority of the patients who had recurrence of arrhythmia, these were not sustained rhythm problems. So these three little lines up here represent how many people had more than 6 minutes of AFib. The majority of people had less than 6 minutes of recurrent arrhythmia. So again, this also speaks to how we measure success. This is a posterior wall trial, POBE-AF. And this study looked at single procedure success if you do posterior wall isolation. That's the graphic represented here. This is our left veins up here and the right veins here. You can see the grayed out area is the electrically isolated area. So the veins are isolated, the posterior wall is isolated. And in this study, what they showed is that there was not actually a benefit to posterior wall isolation. Well, I just showed you a meta-analysis where there was significance or benefit to posterior wall isolation. The explanation here, and the reason I show you this graphic, is that when they took a look at the folks who had repeat ablation, now granted, it's not a lot of them. Out of 200 patients, only 13 had the repeat ablation. The vast majority of them had reconnected pulmonary veins, 85%, and 2/3 of them had reconnected posterior walls. Posterior wall isolation, in my mind, represents the single most significant add-on or potential benefit to treating folks with persistent AFib, but it is extremely technically challenging to do in a durable manner. And I think that's what this study shows us, is that with the current technology and with the current techniques, durable posterior wall isolation with a radiofrequency catheter is hard to do. And it takes a long time and recurrence rates are high with a single procedure. So I think this isn't an indictment on posterior wall isolation because most of them didn't actually have their posterior wall isolated. Instead, it is an indicator that this is a difficult task with a radiofrequency catheter. Left atrial appendage isolation had the biggest benefit in that meta-analysis. Again, small numbers, but unfortunately, we see very high rates of stroke in patients who undergo left atrial appendage isolation. That stroke is mainly driven by even transient interruptions in anticoagulation, but the stroke risk can be as high as 15%. And that's a big deal, I think. To me, that's a non-starter for left atrial appendage isolation with a catheter if you're subjecting your patient to 15% stroke risk. Though, interestingly, if you couple left atrial appendage isolation with some sort of occlusion device, like a Watchman or a Lariat, the rate then drops quite a bit, 22% down to 4% stroke risk if you are able to close the atrial appendage after you isolate it. This is a graphic of the Convergent study. This is Dr. DeLurgio's baby here that he did a lot of work on here at Emory. This is a big study looking at convergent hybrid surgical ablation, wherein using a unipolar ablation paddle and a subxiphoid approach. So this is not open chest, but rather a keyhole incision at the subxiphoid region. A ablation set is delivered by a cardiothoracic surgeon to isolate the posterior wall, as well as to treat the antrum of the veins as much as is accessible by that approach. And you can see sort of an example of some of the treatments that might be done around the veins. And the add-on is essentially after the surgeon is done, the patient comes to the EP lab, and the anterior portions that are missed around the veins are completed with a radiofrequency catheter to complete the pulmonary vein isolation. The comparison in this trial is this complete posterior wall endocardial and epicardial ablation with pulmonary vein isolation in the surgical set compared to pulmonary vein isolation with a roof line in the endocardial set. This was a very aggressive study in that it randomized only patients with persistent AFib or longstanding persistent AFib. When we look at the entirety of the data preceding this study, this is the most sort of advanced AFib population that has been studied in a randomized trial. 95% of patients undergoing the Convergent study had a less than 5% AF burden at 12 months, which is just remarkable. The other thing is that these patients were frequently off all antiarrhythmic drugs after, and this is a fairly significant improvement. The safety rate was very good. It's 2.9% through 7 days and 7% or so through 30 days. So you do buy risk with the surgical ablation, but the risk is not high. The potential benefit in terms of AF suppression and rhythm control is pretty massive in this. So to me, I feel like Convergent, this procedure, this is our current heavy hitter. This is the sort of the single best way of using one procedure to fix AFib. It comes at the cost of being a more aggressive procedure. Vein of Marshall ablation is a evolving newer thing. This is another persistent AFib study where the vein of Marshall runs in the groove between the left atrial appendage and the left pulmonary veins. This is a tough place to treat with a catheter for a number of reasons. The muscle is thick. It's hard to get stability there. And so a technique was developed out of Houston by Valdebarano and others, where the vein of Marshall, you can see it here on the graphic, is engaged through the coronary sinus. A little catheter is advanced. A balloon, over-the-wire balloon, is advanced into the vein of Marshall. The vein is occluded with the balloon, and alcohol is injected. This is the same way that we do septal ablation in the hypertrophic cardiomyopathy patient. Though this is in the venous branch, not an arterial branch, and quite frankly, a lot lower risk in terms of not spilling into and causing a big MI. What that generates is a very large ablation set. So you can see here a picture where purple is healthy, and pre-ethanol, you see a good big chunk of tissue that's healthy, and after the alcohol ablation, this whole area is treated. So this is a way of very effectively and rapidly treating critical areas of the heart. By adding vein of, here's another picture of a case we did a few weeks ago. This is a guide catheter placed into the CS and then a IM guide placed. And you can see the hand injection shows you the vein of Marshall here. And this is a post-alcohol ablation. They all seem to develop this blush here, but this is the area that the alcohol ablation would have treated. This little blush here is an LAO projection. So the left veins would come out over here, and the appendage would sit in foreshortened right about here. In that case, that injection got us this much territory. It was a pretty massive amount of myocardium that we were able to ablate with the vein of Marshall injection. So much so that we didn't have to do radiofrequency ablation. You can see the dots are where we treated. We could skip this whole area and generate pulmonary vein isolation and mitral annular isolation very rapidly. So in the Venous Trial, when you add vein of Marshall alcohol ablation into AFib ablation, you get basically a 10% benefit in addition to pulmonary vein isolation. So it's a fairly easy and rapid way of doing more durable ablation and gaining some benefit. It treats both the ganglion plexi that lives here, plus treats potential mitral annular flutter, which may develop down the road and be a risk to drive future arrhythmia recurrence. So Again, this is an AFib burden graphic, and you can see here that the burden after ablation here at 12 months is very, very low, 0.2%. Everything is like 0.1% or better. So these ablations, while they may not completely get rid of every 30-second or 5-second burst of AT, and they do an excellent job at reducing burden, and vena marshal ablation seems to be additive in that regard. This is maybe one of the last trials we'll discuss, and this is the efficacy of antiarrhythmic drug therapy, amiopropapanone, for maintenance of sinus rhythm versus ablation in a exclusively persistent AFib and longstanding persistent AFib trial, or excuse me, group. This is done out of China. And this is a pretty remarkable graphic. This is unlike anything we've seen before. They did a very extensive ablation. So this was take patients who are in AFib, bring them to the lab, do the pulmonary veins. If they stay in AFib, add lines. If they stay in AFib, do the posterior wall. If they stay in AFib, do complex electrogram ablation, and finally convert. So these patients had all of those add-ons that we showed earlier. And here, the ablation arm, this is the proportion of folks who do not have AFib. So the higher up you are on the graph, the more likely you are to not have AFib. And you see that the ablation arm is way better than the pharmacotherapy arm. So I think this tells us that certainly this is another study looking at persistent AFib showing the efficacy of ablation over antiarrhythmic drugs, even in a more advanced strategy. I think this mirrors what we saw with Convergent to some degree, where the more you do, the better off you're going to be. You just have to make sure that all the lesions are durable, which is hard to do. Let's see, let me check my time and speed through a few here. So we're about to be done. So I'll just give you a case presentation here to highlight AFib and heart failure. So this is a gentleman that was treated here at Emory. I saw him for a Flutter. He converted on his own, was asymptomatic. A year later, he showed up in cardiogenic shock with this echo. He was put on amio, gotten heart failure care, seemed to improve his congestion, but never could wean off the inotrope. So we were faced with a decision of what do we do with this guy? Do we ablate his node? Do we give him an LVAD? Well, what we did with him is we brought him to the EP lab and we did ablation of his AFib. I opted to use a cryo balloon. This is a picture of the right pulmonary vein here being occluded, mainly because I was trying to get in and out quickly on a guy who's pretty sick. We were able to wean his inotrope the day after ablation. He was discharged on heart failure medicines. He's had maintenance of sinus rhythm out to a year. His ejection went from that 15% that I showed you up to 55% fairly rapidly, and has been durable. This outcome is pretty normal, I think, for appropriately selected patients. This is a randomized trial of AF ablation and non-ischemic cardiomyopathy predominantly, and what it shows us is that you can recover your EF and do better if you are able to ablate AFib in an appropriately selected population. This is a case I think Mike Lloyd did, where you look at BiV pacing in folks who have AFib, and you can see as AFib, this big black bar here is AFib coming on, you see the BiV pacing drop off. And with ablation, which happened right here and required cardioversion right here, you see that the BiV pacing shoots back up to 100%. So this is a way of optimizing heart failure outcome, is to get rid of the AFib. Another way to do this is to ablate the AV node, but the way that this maintenance of sinus rhythm mechanism, I think, does have additive benefit if it can be achieved in the heart failure patient. This is a pretty sick guy, big left atrium, 40 square centimeters, with a bad EF. AFib in heart failure has been looked at in quite a few trials, and again, in the appropriately selected patients, what we see is that there is a reliable improvement in EF in most trials, and it does seem to favor ablation or at least aggressive therapy. So it's something that we should think about in our heart failure patients. This is I'll just skip that. This is a bunch more AF trials in heart failure, and they all seem to show the same thing. It favors ablation. Mortality here in a group of studies favoring ablation. Let's see here. So why doesn't it work all the time? Well, it comes down to every ablation lesion has to be perfect, and heart failure has to be optimized, comorbidities have to be optimized. Here's a flutter that came on in a patient who was post-ablation. You can see it just navigating a little gap in what was a previous line created across the anterior mitral valve from the right pulmonary vein all the way down to the mitral valve. There's a little gap here, and so you get a flutter that goes around and around. Here's another flutter with no gap. This just a de novo sort of thing that occurred in the posterior wall. And you can see kind of this figure of 8 double loop. You can follow the arrows and you can see it kind of just spinning around. And this just took a little bit of energy application here to terminate. And these are some of the rhythms that we see when people come back with AFib or A-flutter after ablation. Let's see. So let me just give you some of the conclusions here since we're all out of time here, and I'll open it up for discussion. I think persistent AFib is a potential target for therapy to address symptoms. I certainly think we should be considering AFib ablation as a potential reversible cause for heart failure with reduced EF. We should tell folks upfront and expect as clinicians that many will require more than one ablation, particularly for persistent AFib. This most likely requires more advanced lesion sets compared to paroxysmal AFib. I firmly believe that pulmonary vein isolation alone is not good enough for persistent AFib. And while, you know, I can't show you the one randomized clinical trial that shows that, I think that the preponderance of the data is pointing this direction. Convergent procedure, I think, is something we should all think about in more advanced cases of AFib or cases where a more definitive fix with one procedure is desired. And I think the parting thoughts here, the big ones are, for every positive AF ablation trial, you're going to have a negative one. And this is largely related to the outcomes we're measuring. If your goal is to have 0% AFib, you're never going to achieve that. The procedure won't work. The goal is symptom elimination or reduction in AFib burden. Well, then the procedures, AFib procedures, work extremely well. The types of presenting symptoms will tell us how best to treat. If the symptoms are all heart failure, it may just be that the patient needs Lasix and not, you know, an aggressive rhythm control strategy. If the strategy is aimed at rhythm control because they're feeling irregular pulse rate or palpitations, then I think that tells us that an ablation strategy may be more beneficial and tailored to the patient. I think we should be enrolling very aggressively in AFib trials. There's a lot to be learned here. It's an evolving field, and unless we participate in that learning, we're never going to get the answers. So I think that's a call to arms, I think, for all of us as we see patients. We should be trying to find folks that we can enroll in these studies. And we should be designing AF trials with more individualized treatments and smaller inclusions. Having a one-size-fits-all approach is just not going to work. And I think, you know, my personal caveat, we should be referring more AF more AF patients for evaluation. That does not mean we should be referring all AF patients for ablation, but we should be thinking about how best to optimize the care of the AFib in all of our patients. For some, that'll just be risk factor modification, losing weight and treating sleep apnea. For some, it would just be, you know, anticoagulation and rhythm or rate control with medications. And in some, it'll be ablation. But I think we should be thinking about this more and more as a treatment goal. All right, that's I'll open it up to thoughts here from the group.
Thank you, Anand. That was fantastic and a very nice review and update for managing this problem of persistent AFib. While it is 8:30, but we'll take a few questions while people are typing in their questions in the chat. Dr. Smith has a comment about the Cabana trial. Go ahead, Dr. Smith.
Yes, and a great talk, and I agree about your comments about targeting these trials more. So the Cabana trial had, you know, very broad entry criteria, basically related to rhythm, not necessarily to symptoms. And they knew in advance that 25 to 30% of patients would cross over to ablation, and it was designed as an intention to treat. But then when the results didn't come out positive, they said, well, look, 25 to 30% of people actually crossed over to treatment. So as you know, that's been highly criticized, that that comments have been made that patients crossed over to the treatment arm, and just to know that in advance they knew people were going to cross over.
Thank you, Dr. Smith. Are there any other questions? If not, I'll ask a question, Anand. What is known about, so in terms of our geriatric population, the very old, so greater than 85, for example, in age, would you recommend this for that population as well?
I think it's a very rare octogenarian patient who, once you get over the age of 85 in particular, that needs an AF ablation or will stand to benefit from one. What we know about patients who are over 80 who go through ablation of AFib, they bear much, much higher complication rates and they bear much higher recurrence rates. I think it usually speaks to the fact that that their AFib is much more multifactorial. Now, I'm not going to say that there's some age cutoff, although in the back of my head, I definitely have a sort of soft cutoff. But I think that you have to be very careful when you get into that older age group because that you're going to accept a much higher complication rate. I had a referral for a second opinion from Augusta not too long ago. A patient of 80 who was 85 with a reduced heart function. His EP had recommended ablation, and I did not recommend that. I recommended that he just stick with his low-dose amiodarone, which was working very well, and careful drug toxicity monitoring. I think that'll bear him more fruit than an ablation at his age. There's a question here: what percentage of persistent improved EF? And it really depends on who you target. But one great study, the camera MRI study, where they took folks who had minimal scar on MRI and a non-ischemic etiology of their AFib, I think those folks, that it was more than 2/3 who improved their EF by at least 5%.
Dr. DeLurgio has a comment.
Yeah, I think that's his question, or his comment there is that, looking early, both early AF and stop AF enroll patients who had in stop AF persistent AFib for less than 1 year. Early AF was paroxysmal AFib less than 1 year. And you see that the early intervention arms that over compared to medication arms, there are very clear benefits. But it is, I think he is right. Durable lesions matter a lot. It's really hard to assess the efficacy of a treatment when you can't get the treatment right in the first place. So in some cases, we've kind of jumped ahead of where we need to be, where we're saying, does AFib ablation cure AFib or really, really help AFib, when we're still really sorting out how to do AFib ablation in a durable manner. He's right. There's a lot of new technology out there. It's a fascinating and evolving field for sure.
So, when I think of AFib, ultimately, I guess I think of sort of adrenergic and cholinergic imbalance locally. And so I wonder, what are your thoughts about if we do an ablation, and then what if we send the patient home and say, if this happens, if as soon as the AFib triggers or as soon as you have palpitations, do vagal nerve stimulation or something to try to prevent it. In other words, something else that we can do to quickly sort of alter that high adrenergic tone that may trigger.
I think that the vagatonic and adrenergic AFib they are entities, but I don't think they are as common as we think. I think that's the more, especially in the 60, 70, 80-year-old group, that's more the exception than the rule. But I think that folks with adrenergic or vagatonic AFib often do figure out ways to get themselves in and out of, to get themselves out of AFib. And certainly for the adrenergic ones, just beta blocker alone can be extremely effective at preventing AFib without needing to go through ablation. Dr. Lloyd and I we were talking about a patient not too long ago with adrenergic AFib. It can be hard those are folks where AFib ablation seems to be really challenging. That does seem to be clearly some trigger that is non-pulmonary vein that we don't really understand. They seem to come back a lot.
Okay. Any other questions or comments? Okay, great. Thanks.
Thank you.
Anand, that was fantastic. Thank you.
The preceding program is copyrighted by Emory University.